adolescent health and aging at the World Health Organization in Geneva, Switzerland. Dr. Nisra is a pediatrician and epidemiologist with extensive expertise in improving the health and well-being of newborns and children. He oversees research, development efforts, including guidelines, guidance, and implementation strategies aimed at enhancing the management of newborn infections, childhood pneumonia, as well as diarrhea. He has authored over 90 scientific publications in peer-reviewed journals, and he's on the International Advisory Board for Child Health Research Development, including several research projects in low and middle-income countries to improve child survival and well-being. He's going to share with us tools for frontline healthcare workers to manage childhood pneumonia, looking at the global perspective. Dr. Nisra, you're welcome to make your presentation.
Bismillahirrahmanirrahim. Assalamu alaikum. Very good day to everyone. And thank you, Rebecca. And thank you very much, Union, for giving us this opportunity to present one of the important work around pneumonia management through frontline health workers. You know, pneumonia is one of the biggest killers. So I will start, sorry. So I will start my presentation by saying that I have no conflict of interest to report. So let's talk about something statistics around burden of pneumonia in children in terms of morbidity and mortality. In terms of morbidity, we can see that there are 231 episodes of pneumonia per year in children less than 1,000 children less than 5 years of age. 5 countries, India, Nigeria, Indonesia, Pakistan, and China contributed about 54% of these episodes per annum. However, between 2000 and 2015, we have seen some reduction, about 30% in pneumonia episode. It was 178 million during the year 2000 and reduced to 138 million in 2015. In low and middle income countries. At the same time, during the same period, we have seen an increase in pneumonia admission 3 times in low and middle income countries. In terms of mortality, as Rebecca mentioned, pneumonia is still the #1 killer in 1 to 59 months of age. And globally, it is estimated that 0.73 million deaths attributed to pneumonia in children in 2021. About 80% of these deaths are occurring in the post-neonatal period, which is from 1 month to 59 months of age. And these deaths are not evenly distributed throughout the world. It's only 2 major regions which are contributing 78% of these deaths. These are Africa and Southeast Asia, where most of these deaths are happening. Again, 5 countries contributed about 50% of these deaths: India, Nigeria, Pakistan, DRC, and Ethiopia. And having said that, in the 5, we have seen that it is the 3rd most common cause of mortality in 5 to 9 years age group also. If we see the trend in reduction of mortality related to pneumonia in under 5 in the last 21 years of this century, you can notice it that from 2000 to 2001, there is about 0.9 million reduction in mortality due to pneumonia, which is about 54% from 1.6 million to 0.7 million in 2021. It seems like we are on average reducing 41,000 deaths per year. However, if we divide this 21 years into 2 sections, the first 15 years from 2000 to 2015 and then onward, you can notice that in the first 15 years of this century, we are reducing about 46,500 deaths per year. However, in the last few years, the pace is not the similar, and now we are on an average reducing 24,000 deaths. So that means we need to do some other work to reduce further mortality related to pneumonia in children under 5 years of age. So in that, what is the response of WHO in reducing the pneumonia mortality? I will start with the Global Action Plan for Prevention of Pneumonia and Diarrhea in Children, which is an action plan which categorizes intervention into 3 major areas: protect, prevent, and treat. All these contribute to reduce the pneumonia-related morbidity and mortality in low and middle-income countries. And this action plan was launched by WHO and UNICEF in 2013. So in protect interventions, such as exclusive breastfeeding, adequate complementary feeding, so we know that these good health practices can reduce morbidity and mortality related to pneumonia or any other infections. Similarly, for prevention, there are some specific activities which is related to pneumonia mortality and morbidity, such as vaccination, reduce risk factors, such as household air pollution and others, and then prevention of HIV and prophylactic treatment for HIV not to happening pneumonia. The third important component is the treatment. That is when the child develops pneumonia, what to do. So the most important thing is to improve care seeking and referral system. Second is case management at the facility as well as at the community level, because we know that most of the cases are actually a non-severe pneumonia, which can be managed at the community or at the facility level. They don't need hospitalization. The third important component is supplies of medicine, antibiotic mainly, and oxygen with pulse oximeter whenever it is needed. And obviously, continuous breastfeeding and other good practices to reduce mortality related with pneumonia. So this session only focuses on the third component, which is treatment, not the first 2 components, protect and prevent. So in terms of treatment, the principles of management are quite similar, like which we have many other diseases same. That first thing is identification and care seeking by the family members or by the parents. Then through health workers, they can assess, classify, treat, or refer that child to a higher facility. The third important component is the use of antibiotics. And because we have seen that appropriate use of antibiotic can reduce mortality due to pneumonia. And similarly, when to use oral and when to use injectable antibiotic depends on the severity of the disease. The fourth component is oxygen treatment and monitoring through pulse oximetry, because we know that hypoxemia is associated with poor outcome, and this is one of the complications of pneumonia. And the treatment is to provide oxygen. The next is informing caregiver about home care when it is needed, consult them about the danger signs, when there is no need for hospitalization and only home treatment is appropriate. And lastly, our routine follow-up for the sick child in the community and at the facility level. So having said that, the principles of the management, this is the conceptual framework. A much overcrowded slide, but I can simplify it that any child who has the sign and symptoms suggestive of pneumonia or acute respiratory infection, there are 3 levels of care. And these 3 levels of care are community level, first level facility, which commonly we called it as a primary level facility, and then the hospital level, maybe sub-district or a district hospital level. At each level, especially at the community and at the facility level, we use clinical algorithm to classify and treat pneumonia whenever it is possible. And at the hospital level, we have not only clinical algorithm, but some lab and radiological services to classify further pneumonia into different categories. So if you see at the community level, the community health worker, which is trained in, we call it as integrated case management, they can actually classify pneumonia based on their assessment of clinical signs, which are fast breathing, counting of respiratory rate for 1 minute, and age-appropriate cutoff to declare it fast breathing, lower chest wall in drawing, and other danger signs. So they classified it based on these clinical algorithms into no pneumonia, which don't need any antibiotic, only home care and follow up with some counseling to the parents about danger signs. Then fast breathing pneumonia, which need antibiotics, amoxicillin, oral amoxicillin, and home care with counseling about danger sign and when to come back to the or visit the community health worker. But two important areas, that is chest indwelling pneumonia and danger signs, community health worker actually referred them to a higher facility for further management. The only difference from community level to the primary level is that chest indwelling pneumonia can be treated at the primary level facility with oral amoxicillin if there is no other danger sign available. Only one sign with fast breathing with or without, but no danger signs. The trained person, which we call it as an integrated management of childhood illness, IMCI, a trained health worker can use IMCI and classify these children and treat them. But with danger sign, again, refer to a higher facility for further management. And at the hospital or a referral hospital level, they can actually treat the danger sign, which is known as severe pneumonia, with injectable antibiotics and supportive care in terms of oxygen whenever it is needed or IV fluid when there is a requirement. So this is the conceptual framework, and based on this conceptual framework, we have guidance and guidelines on all three levels of care for pneumonia, which is integrated into other illnesses at the childhood. We have ICCM, which is integrated case management, community case management at the community level. The principle is same: assessment, classification, treat, or refer. At the facility level, we have IMCI. The principle is same: assessment, classification, treatment, or refer, and then pocketbook to be used at a referral hospital level. And if we see that most of the pneumonia cases, and this is research-based, 85% is of non-severe pneumonia, which is only fast breathing, which can be treated at the community level with oral amoxicillin 3 to 5 days and no need for referral to our higher facilities. However, we also identify some gaps in the management of pneumonia in children at the lower level as well as at the higher level facilities. First and the most important is parents or family members do not recognize illness, because these are very non-specific signs. Sometimes it's difficult for the parents or the family member to pick up those signs and say this is something. Obviously, there is a danger sign they can pick up very easily, like vomit everything, or like conversion, like lethargic. But fast breathing, difficult breathing, it's very non-specific sign and it's very difficult. Second important gap we have identified is family members do not seek care. Even they know that this is something, but they do not seek care. And the other is with the health system, such as healthcare providers are not well trained to pick up the disease. There are many other diseases going on there. We don't have a point of care diagnostic test to say pneumonia, or in more specifically, bacteriological pneumonia for antibiotic and viral pneumonia. And then there is a low compliance to even referral to a hospital, full treatment, because many of times they stop treatment, injectables as well as oral antibiotic once the child is better with 2-3 days of antibiotics. And we know that sometimes hospitals are not good place for children, and parents need to leave the hospital as quickly as possible. And then we have seen that there is a low quality of care at all three levels of treatment. So having said that, these gaps, WHO started updating the current pneumonia guidelines, which was previously updated in 2014. So it's a long process. The first step was to do some scoping reviews, and we commissioned an independent academic and research institute to do all the scoping reviews. And these were published as a journal supplement in Journal of Global Health. After that reviews, it's 2021 when we did it. We did a stakeholders consultative meeting to discuss the finding of those reviews and identify the area of guidelines to update. After that, we established guideline development group. We finalized the scoping and research question for systematic review of evidence synthesis through guidelines development group. And then the second meeting, which was last December, we conducted to finalize the recommendation. And now we are going to launch these guidelines quite soon. So I want to just tell you what were the thematic areas which identify to update the current guidelines. The first thing is to improve the diagnosis of pneumonia. We know that these are some sort of non-specific signs and they have a fairly good sensitivity, but at the same time, they have a fairly good specificity. But we are still, sometimes we are treating children which do not need antibiotics. So we want to see the new technologies such as lung ultrasound, digital stethoscope, and cough sound, their role in the diagnosis to improve the current diagnosis of pneumonia. Secondly, to see the additional clinical signs. When pulse oximetry is not available, can we identify hypoxemia based on clinical signs? The second important area is treatment with antibiotic by ensuring the antimicrobial stewardship. We even try to see whether some of the pneumonia, we don't need antibiotic at all. At the same time, can we treat some of the children with pneumonia on oral antibiotic, as well as the place of treatment, whether in the community or at the facility. And one important area is risk differentiated care for high mortality risk, because we identify few risks through IMCI and ICCM, but there are some additional risk factors for which they need differential care, not the usual care which is offering by the moment. And lastly, the important area is 5 to 9 years of age. Currently, there is no recommendation from WHO how to assess them and how to treat these children. So in terms of progress and way forward, we have completed step 5, that is, we have now approved recommendation by WHO review committee, approved it, and the product is in the production phase, and we will launch it in the next few weeks, hopefully. After that, we will update the tools which can be used as a health workers. They are already using it, but with the newer guidelines, we will update it, ICCM, IMCI, and pocketbook. That is all the 3 levels. Then we will work with the countries to change whenever there is a policy change. And lastly, we will do the implementation research in some of the countries to see how we can incorporate this in the routine health system and how we can learn lesson from here to scale it up. With that, I would like to thank you, all the members of development group, guidelines development group. We have 26 members from different specialities. Some of them are clinicians, some of them pediatricians, some of them program directors. Then special thanks to USAID for providing fund to complete this. Thanks to Research Institute for doing the scoping reviews. Melbourne University did some for the pneumonia studies. And then later on, SAS India do some further reviews. So thank you to them, and thank you to all my colleagues at WHO. So with that, thank you very much for listening to this presentation. Thank you. Over to you, Rebecca.
Thank you, Dr. Nisar. Protect, prevent, and treat the children. Our next presentation is around implementation research on accessing treatment for children with pneumonia, sharing experiences from Malawi. This is a recorded presentation by Dr. Hafrez Nsona, who was unfortunately unable to be with us, but he's a program manager and head of the Integrated Management of Childhood Illnesses with the Ministry of Health in Malawi. He's a global health expert with experience in designing and planning health activities around integrated management of childhood illnesses, as well as integrated community management of childhood illnesses. He's also the principal investigator of the WHO-coordinated implementation research to improve the treatment coverage of childhood pneumonia in Malawi, and he's going to share some lessons from that project. I request the IT team to play the recording of this session. Thank you.
Hello and greetings from Malawi. Apologies, I was not able to join in person, but I'm happy to share with you our implementation research on pneumonia coverage in Malawi, lessons learned and way forward. This is a continuation of a series of presentations for this section, and I work with the Ministry of Health in Malawi, but what I have to indicate here is that I have no conflict of interest in relation to the work that I will be talking about here, and please allow me to proceed. So Malawi, alongside 4 other countries of Ethiopia, India, and Bangladesh, are conducting a multi-country study on enhanced management of pneumonia in the community for under 5 children. This implementation research aims to increase the treatment coverage for under 5 children in the district, in one of the districts rather, focusing on the community-based management of pneumonia by the integrated community case management trained HSS using oral amoxicillin and pulse oximetry. The study is leveraging the trained HSS to manage 2 age groups, 7 to 59 days old with fast breathing, but also 2 to 59 months old with chest indrawing, with a 7-day course, but also a 5-day course, respectively. We are enrolling, therefore, those ages into the study. And we started in August 2022, and we expect to finish around June 2025. We are using a district health system model to enhance health service delivery in our implementation. So, as a matter of introduction, we introduced as a country ICCM in 2008. We are having a coverage of around 4,163 out of a total of 6,386 hard-to-reach areas. And for your information, Malawi has its 87% population in rural who needs to access these services. And Kasungu is one of the districts which has 245 ICCM sites. So we are performing and conducting this study in parts of those 245. The HSAs in Malawi, manage pneumonia, malaria, and diarrhea. And in Kasungu, it has 38 facilities, 37 being health centers, but also 1 district hospital, which serves as a referral facility. We shifted our management in pneumonia from cotrimoxazole use to amoxicillin in 2013, where our focus in the implementation of ICCM has always been for children aged 2 months to 9 months. But the HSAs have been the cornerstone of managing ICCM in Malawi at the community level. We are therefore conducting the implementation research to increase the pneumonia treatment coverage for children under 5 years of age by up to 80% in the district. But specifically, our secondary objectives include to evaluate the feasibility whether the ICCM trained HSS can manage chest indrawing pneumonia, but also whether they can manage fast breathing pneumonia among children who are 7 days to 9 days. We also want to assess the treatment adherence among those children who are managed. And the third one is to identify facilitating factors. What are the barriers to implementation and challenges associated with this introduction of the new intervention against what they have always been doing? But we also want to assess the feasibility of them using a pulse oximeter and whether this is acceptable at community level. So when we talk about what are the enhanced management of pneumonia. Specifically, what I'm saying is we are targeting ages 7 to 59 days, but also 2 months to 59 months old children. When you look at this table, the current ICCM does not, in the right frame at the moment, allow management and treatment at the community level. That's why if a child is identified, they only have to refer. But in the new intervention, for the 7 to 59 days, they are allowed to treat. And that's what is happening within the HSAs who have been trained. And for the 2 to 9 months of age, for those that have lower chest injury, the current ICCM protocol is referral, but for the new intervention, we are saying they have to refer, rather they have to treat, and that's what currently they have been trained to do, and they are performing this task. So the main activities included in these processes, are the orientation of stakeholders. Who are these stakeholders? At national level, we have the senior management team of the Ministry of Health. We have the district health management team. The planning meetings we have had with the district health management team itself, but also conducting an assessment with the health facility themselves to check readiness. And similarly, we performed community sensitization, we did baseline survey, adaptation of materials to ensure that there is readiness in terms of when the CHWs are trained, they are trained according to the new protocol on the new interventions. So they started enrollment. Case validation was also one of the exercises and the activities that were done for health facility in charges, and supervision and mentorship, as well as inpatient case management. Therefore, we trained the hospital staff, those that are in the nursery pediatric wards, but also the neonatal wards of the district hospital, so that they can be able to manage and take care of these these cases, once they come from the community themselves. What we are learning so far is that the trained HSAs are able to identify and assess cases. They are able to do a classification and be able to make a decision whether they should treat there or indeed refer. So far, 457 have been enrolled since we started the study, and we have experienced no death. And no death, that's what I mean, no death. And the 100 among sick young infants, and 357 the children with chest injury pneumonia. And we have also learned, and we are learning, that HSAs are able to use pulse oximeters to measure oxygen. So the measure of oxygen using pulse oximeters helps them to make treatment decisions, whether they cut off of oxygen saturation of 90% or less, so that they should refer to the next level, or indeed enroll if it is above 90% in the absence of the other critical signs in a sick child. And the pulse oximeters that we are using are the Massimo ones that we were provided and given by WHO, and these were given as a matter to validate the work, and they were distributed to all health facilities in the district. We have also learned that clinical mentorship is being facilitated and is taking place very well, and it is one of the critical components that strengthens implementation. On performance contribution, on the MPIC study, on DHIS2, which is our reporting platform, we've learned, and we are learning, that the reporting rates for this district is way off promising and encouraging compared to the other 4 districts which are in the same zone. You know, Malawi has 5 health zones, and the reports come by health zone. So in this health zone, because of this study, we have observed and we keep learning that the DHIS2 performance in terms of reporting rates is very high for the district, and it's attributed to nothing else apart from the implementation research. Availability of medicines has been encouraging, and we have ensured and facilitated strengthened delivery and availability of medicines to all the districts in the country because of the introduction and after the introduction of the study in the districts. On average, the months of stock and stock on hand based on the average monthly consumption is around 3 months. And on average across the country is right now within 2 months period, and around rather 2 months period. And that's encouraging. And the study has ensured and is ensuring consistent availability of amoxicillin at community level. Just for your information as well, those that are referred for treatment because they have to be admitted at the district hospital setting, we have a total from a pooled data from December to September, 665 admissions. Out of those, 261 came from the communities where the intervention is taking place. When you look at your right, you see that the referrals coming from the intervention facilities are almost zero, while referrals in terms of admissions from facilities that are non-interventions are higher. And indeed, they are recording cases against the total number of referrals in the district. So you will see the comparative advantage that the district is also experiencing looking at the actual data that they have looking forward. Looking at ownership, but also support from the district. I want to emphasize here that the success of this is based on the district team leadership, the district health management team involvement, and also their recognition that they are doing this in response as being a responsive health system unit based on the Ministry of Health vision on the health sector strategic plan, which runs from 2023 to 2030. So there is a lot of acceptability, but also confidence among HSAs. So ownership exists within the district hospital, but also ownership exists within the community. And there is smooth management, but also smooth running of the interventions. And I want to share with you some of the important information, but also testimonies given by caregivers after we conducted our midline. One of them said, "I will never forget when my daughter fell critically ill with pneumonia. She was struggling to breathe and I feared the worst. But thanks to the village clinic and the dedicated health surveillance assistant, she received timely treatment with amoxicillin. Within 3 days, she was back to her prayerful self." That's a caregiver giving testimony during midline. And another one, the father now, said, "I was hesitant at first, but the HSA's expertise and confidence put me at ease. The best part though, we didn't have to spend a fortune on transportation to a distant facility. This program has been a lifesaver for my family, and I'm grateful for the accessible quality care it provides." And one caregiver for a sick young infant said, "This program has transformed our community's healthcare. Pneumonia medicine is now available at our village clinic. This is a game changer for families like mine. Previously, we would be sent to the health center, which meant costly transportation and added stress. But now, even severe pneumonia, that's the very sick cases according to them, can be treated locally. So these are the, instruments, the learnings that we are getting, and finally, this new intervention has attracted and is attracting visits from other partners. Here we see USAID with its mission we have people from Madagascar and the others from Senegal who are accompanying to come and learn from what is happening in Kasumu. And finally, we want to continue the data collection until June 2025. We want a serious discussion. And we are planning for a serious discussion for a nationwide scale to reduce under 5 mortality, the overall under 5 mortality, because this strategy, we believe, is a game changer strategy, using a phased rolling out of the study itself. And finally, I want to acknowledge the mentorship role and the oversight supervisory guidance by Dr. Yasi, senior management of the ministry, the district health management team, and everyone else who is taking part in the study in the district, the health facility, but also the healthcare providers. Thank you so much for listening. And this is the end of my presentation. I know my colleagues will be able to take up some of the questions while I'm not around, but thanks for your listening.
Yeah,
thanks.
Many thanks to Dr. Ansona for really sending us that wonderful and very insightful presentation. I now want to introduce our speaker for our last presentation. He's going to talk about oxygen. Regardless of where you are and who you are, it's a life-saving commodity, but particularly for children with childhood pneumonia. So the presentation is about improving access to oxygen therapy for children with severe pneumonia in low-resource settings, and it's going to be delivered by Professor Stephen Howie, who is an assistant professor of pediatrics at the University of Auckland in New Zealand, and an adjunct professor of pediatrics, public health and epidemiology at the Fiji National University. He has worked in UK Medical Research Council in the Gambia for over a decade as the theme leader for child survival. His research, teaching, clinical practice, and leadership focus on prevention and treatment of high morbidity, high mortality childhood conditions, including pneumonia, through clinical, epidemiological, and public health transdisciplinary approaches. He's a member of the WHO Pneumonia and Diarrhea Guideline Development Group and an advisor to the Lancet Global Health Commission on Medical Oxygen Security. Professor Howe, you are welcome.
Thank you, Rebecca. Let me just adjust that. And thank you to the organizers for giving us this opportunity. We appreciate it, and we feel strongly about this subject. Tēnā tātou katoa, Nisa Bula Vanaka, and warm greetings. And those, I just want to say that those were, that's just fantastic work that we've been hearing about just now, and great presentations. And this is the kind of thing that is really making a difference on the ground. And after those talks, I feel there's a risk that what I'm talking to you about may seem a little pedestrian, a little bit of a no-brainer. Now, predictably, it is and it isn't. The physiology of this is straightforward, relatively. Now, the practicalities are far from straightforward, enough that this whole issue of hypoxia, hypoxemia, oxygen has for many years been in the too hard basket in low and middle income countries. And it's one of those wicked problems, as they like to call it these days. So first of all, just to say that as I load this presentation, that I have no conflicts of interest. Let's get this going. The magic. I have no conflicts of interest to declare. So this is about pulling oxygen out of the too hard basket. So just to start by saying that the international health community we have had something of a love-hate relationship with oxygen. I think it would be fair to say. And that has been because this has been such a difficult issue to grapple with. And it's important right now that we understand that tension, because we really need this relationship to be out of that too hard basket, not a basket case. So what we're going to be talking about today, we'll explore origins, we're going to talk about the dangers of hypoxia, the simplicity of the problem, the complexity and the challenges of addressing it, and the window of opportunity that we have right now to get this out of the too hard basket. It's an important time. So first, to origins. Now, oxygen was discovered in the late 1700s, co-discovered by these two gentlemen, Schiller and Priestley. Now, I don't know if there are any fans of Jane Austen in the room, but if you are one, you might think that one looks a little like Mr. Darcy and the other like Mr. Collins. Now, I doubt, though, that that is actually fair to either of these gentlemen. But it was really the brilliant French chemist Lavoisier who began to understand oxygen's role in respiration. And this was before his tragic end in the tumult of France's Revolution. And this is a reminder to us that even with such potential, things can go horribly wrong. And that is certainly true of hypoxia. And hypoxia, of course, is too little oxygen in the body, in the tissues. And this impairs that respiration. And that leads to energy failure in the cell. And I am going to spare us rehearsing the Krebs cycle and associated biochemical pathways. You will be glad to know. Suffice it to say that that energy failure leads to loss of cell function and the release of toxic metabolites like lactate, like reactive oxygen species. And that impairs the function of bodily organs like the brain, the heart, the lungs, other organs in the body. And this leads to illness. And if it's severe enough, it leads, of course, to death. So that's the theory. And it's good, sound theory. And indeed, there is good empirical evidence that hypoxemia, which is, as you know, low oxygen in the blood, and it's a surrogate for hypoxia, that hypoxemia is associated with mortality from child pneumonia. And Yazir was already referring to that. And in fact, there is a very strong dose-response relationship. And you see that in this graph. You see that as the severity of hypoxemia increases, your chances of dying, if you're a child with pneumonia, also go up. And this is a collation of that evidence, very recently published by Hamish Graham and colleagues in the Lancet Global Health. So it would seem intuitive, again, possibly a no-brainer, that if you have a child who is hypoxemic, that you would treat them with oxygen. Like this would be a happy marriage. And this is interestingly where the story gets a little bit rocky. Now, when I was training in pediatrics in New Zealand, this was not at all controversial, treating children with oxygen who are hypoxemic. When I got into international child health, I found that it was actually somewhat controversial, and that it was so difficult to achieve this in low and middle income countries that the question was asked, what is even the evidence for this? Does oxygen even work? Now, at the time, I confess, that reminded me somewhat of an interesting Christmas BMJ systematic review by Smith and Pell that showed conclusively that there is absolutely no randomized controlled trial evidence that a parachute will prevent you getting injured or dying if you jump out of an aircraft. No evidence whatsoever. So I'm looking for volunteers for that randomized controlled trial. Please, you can put up your hands and come and see me afterwards. Now, this is what this felt like to me. It's very difficult to do randomized controlled trials in hypoxemic children. Almost impossible. Now, the almost is another story that we can come back to. But there is, in fact, evidence that interventions to detect hypoxemia and to treat it with oxygen in children with severe pneumonia is associated with reductions in mortality. Now, I just want to give you a couple of early examples. One from Trevor Duke and colleagues in Papua New Guinea showed a 35% reduction in mortality. Another from Penny Ennison and colleagues in Malawi, again, showed substantial reduction in mortality from child pneumonia. So there are legitimate questions around the edges of this issue, discussions about thresholds, but in the main, this is a straightforward issue. And Yazia has shown us very wonderfully about the WHO guidelines. They just guide us in what we should be doing at the coalface. Suspect a child might have hypoxemia, then diagnose it with pulse oximetry, treat with oxygen. So far, so simple and so happy. But why is it that it is so hard and has been so hard to succeed in this? Now, the estimate is that the best part of 400 million people a year should be treated with oxygen. These are people of all ages and all diseases. So this topic is actually not just about child pneumonia. It's got far-reaching implications. The vast majority of those people are in low and middle income countries. 70% of those people do not get oxygen. That is a huge coverage gap. Why is it so challenging? Well, I just want to pick up on what was talked about before around, first of all, diagnosis. Now, a caregiver has to recognize that their child is unwell and then seek services. And this is not easy in many instances. There are multiple barriers. And I really want to encourage you to get your coffee tomorrow morning, come to the Meet the Expert session, delving into the dynamics of issues of access to care for children with pneumonia. We're looking forward to a really good discussion there. And the kind of work that was being presented by Humphreys before, this is the kind of thing that helps with patients and health services coming together. So next, in those health services, you need an oximeter that is accurate and that works. And this is vital because over 2/3 of cases of hypoxemia are missed on the basis of clinical signs alone. Only around half of general hospitals in low and middle income countries have functioning pulse oximeters. Then you need the skilled staff to use the equipment, to make a diagnosis, and to intervene. And we know how much of a challenge the workforce crisis is around the world. And we know how important skills training is. And the reality is that only 1 in 5 patients coming into general hospitals are getting pulse oximetry measurements. Again, just showing you how the diagnosis is a challenge. Then we need oxygen for those skilled staff to use and to give to these children. Now, this has been in the too hard basket because oxygen has been scarce, expensive, cumbersome, and dangerous. Now, currently, something over half of general hospitals in low and middle income countries have access to reliable oxygen, and this is improving. This was something that was always an issue, and it came into stark relief during the COVID pandemic. And not only was this a health crisis, it became a political crisis as well, and we saw these images of the disastrousness of hospitals running out of oxygen and patients dying, and also the spectre of oxygen storage at times exploding. However, this can be done, it can be done safely, it can be done cost effectively. So there are a number of ways that oxygen gets delivered, as many of you know very well. There are traditional oxygen cylinders. There are large tanks with liquid oxygen. There are oxygen concentrators at the bedside. These work by taking the air, pushing it through a zeolite filter. It takes out the nitrogen, and you get over 90% pure oxygen, which is very good for treatment. A larger version of this technology is a PSA plant, and you'll see that on your right-hand side there. This is a plant from Tonga in the Pacific. The advantage of these technologies is they are logistically simpler. You're not needing to transport oxygen, and they are less expensive, and that's very important. They do need maintenance, they need electricity, and these are important factors. But what we have found through COVID is that all methods are actually needed. They have their place. So it's a case of all of the above. So what is it actually going to take to deliver this? You need strong enough systems, health systems. They need to be backed with policy, with funding, with supply chains, workforce, and biomedical technicians and engineers are really important here, and you have to have the infrastructure. Now, does that feel too hard? For so long, that put this issue in the too hard basket. But systems don't have to be perfect. They just need to be good enough. So we pediatricians are fond of the concept of the good enough parent. Not the perfect parent, the good enough parent. And Winnicott and Bettelheim, they coined this term. And so the idea is that you don't have to be a perfect parent. You just need to be a good enough parent. In the same way, health services, health systems, they do not need to be perfect. They need to be good enough to deliver the care that is going to make the difference. So that's what we're aiming at here, good enough health systems. So how do we get there? How do we actually get oxygen and the treatment of hypoxemia out of the too hard basket? First of all, there needs to be collective intent. And it was a milestone last year that the World Health Assembly made its declaration on increasing access to medical oxygen. So that agreement is vital. But agreement is not enough. You need a roadmap to get there. And the Lancet Global Health Commission on medical oxygen and activities like the Global Oxygen Alliance strategic framework, these are key in this roadmap. The Lancet Commission, a number of the figures that I've been presenting today come out of that work. But even those things are not enough. So the things that I've shown you are just documents. As Leith Greenslade would say, of Every Breath Counts, these are just documents. What does it actually take to get traction on the ground? Firstly, countries need to commit to this issue. They need national oxygen plans with teeth, ministries of health, ministries of finance, and across government and across sectors, combining to actually commit to tackling this issue. Now, why would governments do that? Well, there are some obvious reasons for that. One is that they want their people to be well. They do not want them to be sick. They don't want them to die. That's first and foremost. Secondly, this is a good investment. It's highly cost-effective as vaccines, perhaps even more so. And the return on investment is high. Thirdly, they will do this to manage the political risk. And we saw this through the pandemic. This hit the headlines in a very big way and in a damaging way. And this is something that governments will take notice of. It also needs the funding. The bulk of this will come from countries committing to this. But there is a funding gap. So the Global Oxygen Alliance have made a call for $4 billion over the next coming years to help fill that gap. And one possible mechanism for this, the Global Fund, eighth implementation, will include oxygen. But it's also going to take industry engagement. and business models that serve low and middle income country markets. Now, good work is happening in that space. We've done it for vaccines, we can do it for oxygen. So, to finish, oxygen is a life-saving, essential medicine. One of the things that countries need to do is to get it on their essential medicines lists. The WHO did that in 2017. Countries need to get on board with this. The principles of this are straightforward. The practice is more challenging, but it's not impossible. For the child in front of us, we need carers to be able to recognize illness and for them to connect with services. Please come to that session tomorrow, bright and early, bring your coffee. We need to diagnose these children with pulse oximetry. We need to treat them with oxygen. And this has to happen in health services that are good enough, not perfect. So the intent is there internationally. The roadmap is there. Now it's implementation that matters. That's going to take countries having national oxygen plans with teeth, with funding, with commitment, gaps in funding being met by the international community, and industry coming to the party in these markets. And the rewards for this are actually really obvious. It is about lives saved just now, and this is not just the lives of children dying from severe pneumonia. This is the lives of people at all ages, and not just in lung conditions. Lives saved right now, and readiness for the next pandemic, because that must inevitably, unfortunately, surely come. And we must not lose and forget the lessons that we learned in the COVID pandemic. That would be an absolute tragedy. So a final word, this does not have to be too hard now. That does not cut it. And the good news is that it doesn't need to. We can actually solve this, and it's possible for us to do that right now. And with that, I thank you.
Thank you so much, Professor, for the presentation. I just have one very burning question for Dr. Nisar. We have a significant proportion of children with tuberculosis, but they present with signs and symptoms of pneumonia. I'm just wondering, how can we leverage the WHO tools to identify these children so that they can receive really the care that they need urgently? Very quickly, our time is getting done.
Okay, thank you very much, Rebecca. This is a very key question which you asked, because in many settings we have seen that these are quite similar clinically signs and symptoms with TB and with pneumonia. And we have one big comprehensive review which shows that about 10 to 12% of the children, they presented with signs and symptoms of pneumonia plus TB, and getting the antibiotic first and then the treatment, and then move to the TB, maybe later on, maybe 2 months, 3 months, who knows. So having said that, we are going to update the IMCI, and we try to see that how we can incorporate TB algorithm within IMCI, so that it's easy for health worker working at the prime level facility to actually distinguish between pneumonia and TB cases to a certain extent. We don't have a perfect thing at present, but yesterday we have a very good session on using the treatment algorithms by the primary level facility health workers and how they can improve the TB diagnosis at the lower level. So having said that, we need an integrated approach, not a single approach. So that's the one thing which I would like to discuss with you.
Yeah, thank you so much. Now, in our last minute, I'm just going to invite Dr. Eric to just come and briefly share about the Child Pneumonia Working Group. And I want to really thank you so much for your attention. Dr. Eric, very briefly, please.
Yes, can you hear me? So, I think the main thing I'm up here for is to really cordially invite you all to become members of the Child Pneumonia Working Group. We're very excited about the activities that we have planned over the next 2-year cycle. As I hope that you've gleaned from this plenary session and the excellent presentations, that there's some real reasons to become a member of the Child Pneumonia Working Group, even if your focus is on TB. Child pneumonia, not just the leading infectious cause of death globally for children, but also the entry point for the vast majority of TB cases at the primary care level. And then furthermore, the child pneumonia management ecosystem, as you've heard, pulse oximetry, oxygen, antibiotics, nutritional supplementation for malnourished children. For that, for this to be optimal, when optimized and working towards that optimization through all the implementation work that Steve has alluded to, as well as Humphreys and Yasir, that will inherently optimize the outcomes for pediatric TB cases. And so there's a really, really important synergies between the child pneumonia space and the pediatric TB space. In terms of the working group itself, our mantra is to be useful for members. And so our activities are really formulated around that to make folks want to be members. And so we again invite you. So some of the highlights of the activities that we have planned, we have an annual scientific webinar that's virtual that we'll be holding in June of each year. We have virtual strategic planning sessions twice a year. We're holding those in March and September. We also are initiating a monthly email scientific and policy child pneumonia circular to keep members informed of the latest evidence, policies that are forthcoming, like the WHO guidelines that will be coming from Yasir. We'll be having those circulated. And to kind of do all of that, we are happy to share that we have a funded coordinator that will be starting early in 2025. And then there are some activities that we're very excited about that are contingent on funding. In part, I should mention as well, the 2025 and 2026 union conferences, we really look forward to having dedicated child pneumonia space around perhaps a symposium or two, as well as scientific abstracts. The other activities, just to briefly mention, are a child pneumonia skills workshop that we would really like to implement, funding contingent that would take place the day before the conference, to be useful for healthcare workers and program managers to implement a lot of the evidence-based activities that we've heard about today. And then lastly, we have a program that we would like to initiate called the Child Pneumonia Champion Program, which is intended to build capacity from the ground up on implementation science research, which we feel like is really important to bring that evidence into action. But to do that, that does depend on funding. So welcome all of you to become members, and we look forward to this next 2-year cycle, and thanks. Back to you, Rebecca.
Yeah. Thank you, Eric, and join me to thank the presenters for this session, and thank you so much, all of you, for listening to our discussion. Have a good day.